So we know that the people that present in our clinic tend to have multiple trauma histories, and these traumas tend to have high levels of betrayal. And so then the question is, what are we not addressing? Because betrayal brings up a whole nother layer. They have military sexual trauma. They've had traumas before they got into the military. So what things do you imagine that they're dealing with and they're bringing in the room that we may not be addressing by these manualized treatments? Any thoughts about that? Given your knowledge about what we typically do with prolonged exposure, what we typically do in cognitive processing therapy, what kind of social and emotional consequences are not being addressed when we think about these treatments? They really don't necessarily get to the more relational aspects of functioning that are heavily impacted by these traumas that have high levels of betrayal. Most certainly, yeah. And it just working in treatment with veterans, I've heard a lot of them say, I just don't trust anybody because I don't know how to decipher whether someone's trustworthy or not. Like, people seem to be trustworthy and then they end up doing something that's totally inconsistent with what I thought. So I don't trust them, and not only that, but I don't trust myself to make a good decision. And so it affects, your trust of yourself as well as other people. So that's, a big one. And I will say the cognitive processing therapy does address trust, but it's only just like one session towards the end of the intervention. And when you're thinking about something like child sexual abuse, where you've been living with these kind of damaged relational mechanisms for so long, how can you really address that with just one session? It is, yeah, because we're not addressing some of those more perimeter kind of issues that are still going on in their lives. They come and see us, once a week, twice a week for treatment, but they have all these other contextual factors that are going on in their lives that are having a real impact on just their ability to even engage in treatment and to focus on the trauma. Mm-hmm. Yep, it might be rational, and given, especially if someone's homeless, yeah. All right, and another piece that I wanted to bring up here, so you brought up the trust, I think the shame and guilt, which has been brought up, I think, before in our presentation, and then also this idea of sexual dysfunction. I think that that's something I have a really strong interest in, because a lot of veterans deal with that, and oftentimes that comes as a result of these traumas that they've experienced. One piece that we talked about, or we thought about when we were preparing this presentation, is arousal or even ejaculation during these military sexual traumas. What does that mean for the survivor if this happened? How do they interpret that for themselves, and how does that impact the healing process and just their processing of what's going on for them? And I think that's something that we should think about too in these, clinics that primarily focus on sexual trauma and interpersonal victimization, is that a lot of these other layers that are really important are not being addressed, such as sexual dysfunction. All right, another point. So a big point here was that overall males were not getting better. And so we want to talk about what are the clinical implications of this. So how have, gender role expectations and norms influenced treatment seeking, treatment delivery, and outcomes? Because I think, as someone mentioned earlier, it's this expectation that men should not be vulnerable to sexual trauma, that they should not be experiencing sexual trauma. The male survivor might have thought that before they were traumatized and even after they were traumatized. But also, let's think about us as providers. What are our expectations, and what are the norms that we subscribe to, and how does that impact the way that we deliver these treatments? Any thoughts about that? That's a fantastic question. Actually, at our clinic in Mission Valley, we're seeing the waiting room that they come to is just a general mental health clinic. So it doesn't say military sexual trauma, interpersonal trauma. We don't have that. We don't announce that. And so it's just a general mental health clinic that they come to, and then they're called back, and then they work on their issues with their provider. So there's no signage up or anything like that but that's still a good point that just even seeking mental health treatment could be triggering for some people. And people that are more conscious about that might think someone could know what I'm here for, or there's a lot of women up here, so that looks weird if I'm a male. And we have tried to make a concerted effort, even in our orientation meetings that we have in the clinic, to let people know that this clinic is not just for women. It's for males as well. All right. And so another point that I just want to make here and kind of have for you guys to maybe take home and think about is, what can we do to educate other providers? So say they're not psychologists, but what if they're, in the primary care clinic or in the substance abuse clinic? What can we do to help educate them and help them challenge some of these gender role expectations that they might have, because that can have a big impact, especially when you talk about disclosure and people disclosing for the first time, and what kind of responses that they get, which then can influence the veterans' openness to seeking treatment for the military sexual trauma. So last point I wanted to bring up was this idea of LGBTQ affirmative treatment. And really what I wanted to bring up here and point out is that, people who identify in this category, oftentimes they have ongoing and pervasive discrimination that they're facing. That doesn't just stop after the trauma, and sometimes was there before the trauma and might have motivated the military sexual trauma, so they might have been a target because of their orientation or their identity. And so then that adds an extra layer onto what they're dealing with. And then also, when we're talking about, therapy and treatment, oftentimes it's important, and Herman has pointed out, it's important to encourage trauma survivors to reconnect with their environment. But when your environment is not safe, as you pointed out, and you have, legitimate reasons to not feel safe in your community and re-engaging with your community, what can be done about that? And so one thought that we had was this idea of encouraging veterans and thinking about what they can do to, help to make their community what they want it to be. So how can we encourage them to engage in advocacy so that they can affect change in their communities and in their environments? And I am out of time, so I will stop now. But we thank you all so much for coming and for sharing your thoughts. And we're still having ongoing research, so we're gonna think about some of these things as we conduct this research, and also continue to strive to provide optimal care to the veterans that come to our clinic. We appreciate it. Thank you.